Hi, guys. Hi, everyone. Thanks for joining. See if I can figure out how to make this work. All right. Tell me you're on. Say something in the chat. Let me see it. Let's test this out. Who's on? Where are you from? Talk to me. I see there are people here. Are you guys just being shy? Or am I not seeing the chat? I have to figure that out first. I think I have the chat. Slow down. Hi. Somebody is on. Let me see how I can turn off this comment filter, chat filter thing. There we go. All right. All right. Hi, Dina. Hi, Caitlin. Hi, guys. Okay, thanks for letting me know that I got this to work. So welcome, everybody. My name is Dr. Marwa Kaisey. I'm a board-certified neurologist. I'm an MS specialist. I practice at Cedars-Sinai in Los Angeles. Hi from Boston. Hi, Sophia. Hi, Livy. Quick disclaimer, this is not medical advice, obviously. We're going to be talking in generalizations today, just trying to learn, trying to get educated, hopefully get a little bit entertained too. We're going to be, Montreal, Canada. Hi. We're going to be talking about all things related to pregnancy, fertility, postpartum, and MS, and women with MS and men with MS too. So please have your questions ready. Something about me. So I mentioned I'm an MS specialist. I treat people with MS. That's my passion. I also do research on MS. And the other thing about me that you should know is that I am a mom. I have a beautiful 14-month-old daughter. And it took a lot to get her. We're very grateful for her, but I have been through it all. So I can speak to this on a personal level too. All the fertility issues, miscarriage, the pregnancy itself, breastfeeding after the fact, been there, done that. So I'm with you. Hi from New Jersey. Hi, Pamela. So let's get started. Let's jump right in. We'll do about 30 to 45 minutes, depending on how many questions people have. I don't have anything pre-prepared. Are there any questions from any of you all out there? Where would you like to start? I'll give you all a second to answer. And yeah, we can talk about anything from getting pregnant to the pregnancy itself to there's a lot of questions about breastfeeding usually. It's a very hot topic. Part of the difficulty with this whole subject is that we as physicians get very little as far as guidance or algorithms. The data is not quite there for a lot of these things. The rigorous studies are not quite there. And so we are left to deduce what we can from smaller studies, from retrospective studies, and to sometimes not necessarily go against the official label from the FDA or the EUA, depending on where you live, but try to kind of work through it and work with it because there's not a lot of guidance there. So that is why you may get different answers from different MS specialists. We don't all have the same perspective. We don't all have the same answer. And this is where the art of medicine comes in a little bit in addition to the science, is that we all have different practice styles. So keep in mind that what I tell you may not be the same exact thing that a different MS specialist tells you. So do we have any questions from you guys? You want me to start somewhere? I can just start talking about, here's one. So Excellent question from Pamela Cooper. So, how long after you stop your DMT can you start trying to get pregnant? And how long is the DMT in your system after you stop taking it? So, this is the crux of the issue, right? When somebody's on disease modifying therapy for their MS, which a lot of people with MS are, a lot of women with MS are, and then they want to start trying to conceive. So the first thing to know is that you should be on a good form of contraception until you are really ready to conceive and that you've discussed this with your physician. Because as your question alludes to, Pamela, there needs to be some planning involved, right? We need to know and we need to advise you on when to stop your disease modifying therapy, when you're going to start trying to conceive, and so on. So until you're ready for that, definitely being on a good form of contraception, such as an IUD, is definitely advisable. When you're ready, it really depends on which disease modifying therapy you're on, and it depends on the patient too. So, for some therapies, we have to stop a while in advance. So, one of my least favorite disease modifying therapies for anyone who wants to try to get pregnant is fingolimod or Gilenya. Sorry, not sorry. There are a couple of reasons I don't like this medication. One, if you don't stop and you get pregnant, there is a real risk of fetal malformation. So it can actually harm the baby in their development. Two, if you do stop, then you're running the risk of a rebound relapse. You cannot really just quit Gilenya cold turkey because after it's out of your system, you run the risk of a severe rebound attack from the MS itself. So it's kind of a you're damned if you do, damned if you don't kind of situation. So I don't love it for women who want to get pregnant anytime in the future, really in the next few years. The way to get around that is to replace it with a different medication. So usually, if somebody's on Gilenya, we have them stop for 2 months and then start a different medication 2 months before they start trying to get pregnant. If they're going to just stop, which again is not advisable, or we replace it with a different medication such as Rituxan or Ocrevus, which we can work with through pregnancy. So, for some of the medications, you don't have to stop until you know you're pregnant. Some physicians will even say you can continue them throughout pregnancy. And these are some of the injectables. So, Copaxone and the interferons. And those include things like Rebif, Betaseron, Avonex. Those you can pretty much continue until you get your first positive pregnancy test. And again, there are some physicians who will tell you to just continue it throughout pregnancy because they are that safe. And we do have some data on this. We have thousands of women who've gotten pregnant on these medications, and we pretty much know those are safe at this point. Another medication or type of med that you do not have to stop are the every 6-month B cell depleting infusions. So there are two of these. I'm talking about Rituxan and Ocrevus. So these are some of the best choices if I want to continue somebody on a medication throughout their not throughout their pregnancy, sorry, to give them protection while they try to get pregnant. So we don't necessarily have to stop them because they're only dosed every 6 months. So for these medications, the amount of time that the drug is in a person's blood or in their body is shorter than the amount of time that they are protected from the MS from this medication, right? So the effect of the medication lasts longer than the medication itself. The other thing is that they're large proteins. They are not going to cross from the mom's body into the baby's body until the second trimester. So even if the medication is not out of your system while you're in the first trimester, the baby's not getting exposure to it through the placenta. So all that to say that in these medications, really you can probably start trying to get pregnant about 6 weeks after your last infusion. And even if you happen to get pregnant right away, there's not a lot of risk to the baby. Or really, you can't say no risk because we don't have these huge studies, but theoretically there's no risk to the baby. But the mom now has protection for 6 months. It's 6 months of trying to conceive where we're not worried about is she going to have a relapse, she's not protected, and so on. So those medications, the Copaxone, the interferons, and Rituxan or Ocrevus, you actually don't have to stop until you know you're pregnant, right? You don't have to have a washout period. With Gilenya, it's 2 months is usually recommended, 2 to 3 months. But again, we don't want to just stop cold turkey. We want to replace it with something else so we don't have a rebound attack. And then one of the other common medications, Tysabri, is the other one where you can have a rebound attack if you just stop cold turkey. So that's one I don't like to use in pregnancy. especially towards the end, the third trimester. There can be problems after delivery with the baby, people on Tysabri. But if someone happens to get pregnant, we either stop it or we kind of taper it off. We give it every 6 to 8 weeks, for example, just to give the mom enough so that she doesn't relapse and continue that one. Tecfidera is an easy one in that it's out of your system in a couple of days. So typically, most people say 0 to 1 month with the Tecfidera, but really the reason you take this medication twice a day is because it's out of your system so fast. So it really only takes a few days before you can start trying to conceive with Tecfidera or Vumerity or DMF, which is the generic version of that. Cladribine, you shouldn't try to get pregnant for, I believe it's 6 months. I don't use this medication, but 6 months after your last dose. And this one's only usually dosed twice. So, second dose, 6 months later, you can start trying. And with alemtuzumab or Lemtrada, it's 4 months. But the tricky thing with Lemtrada is you have to continue to monitor the mom because you can have secondary autoimmunity, things like thyroid issues for up to 4 or 5 years after the last dose. So that's kind of the big picture. If there are any specific medications that I didn't mention or that I went too fast and you guys want me to repeat it, please throw that in the chat and I can go back to it. But that's kind of the big picture overview of the different medications and how long you have to stop them before you start trying to get pregnant. If it's safe to even stop them, again, with Tysabri and Gilenya, it may not be completely safe to just cold turkey the mom. Sometimes we do that, or we used to do that, but there's a risk of a rebound attack during pregnancy if you do that. And then other medications, you just have to stop a few days to months in advance. So next question with Katie Davis says, are there any adverse reactions or negative outcomes in patients with MS who receive an epidural while in labor? So short answer is no. Short answer is no. For women who have mild to moderate MS, who don't have significant mobility issues to start with, significant conduction problems to start with, this really should not be an issue. So the advice that I give a lot of my patients who I usually have them come see me after they know they're pregnant, we celebrate, we do a little dance, assuming that that's something they're happy about, of course. And then, I tell them, one, make sure your OB knows who I am. So any questions they have, they can call me. And two, here's a general rule of thumb for you and your OB. The MS should not directly affect your care and your decisions around the delivery, right? So if you want an epidural, go for it. If you don't want one, power to you. I don't understand it. I wanted mine as soon as I walked in the door for my delivery, but you don't have to have one, right? The MS doesn't affect that decision at all. If you need a C-section, they should do it, but not just for the sake of the MS, So there's a lot of old school thinking sometimes from OBs about women with MS and what they look like. And that education happened in a time when MS was not as well treated and well controlled as it is now because we did not have the same disease modifying therapies that we do now. So it's not their fault. There's just what they know about MS from back when they were trained, right? Which could have been a while ago. And so their experience with women with MS is different than the real lived experience of today. And so that's my general rule of thumb for most women with MS in most situations, is that the MS should not affect the decisions happening around the time of your delivery. And epidurals are magic. My anesthesiologist was one of my favorite people during my delivery. So if you want one, absolutely, you should be able to go for it. Definitely something to discuss with your neurologist, though. There are some rare exceptions. But in general, yeah, if you want one, it's totally fine. A question from Monica says, I'm interested in information in regards to IVF, and I read that failed IVF can be potentially dangerous for severe relapse with new symptoms due to the hormones that one must take. So great question, Monica. And this is based on a few very, very, very small studies that looked at women with MS who were treated with max Copaxone, right? They either weren't treated or they were on one of the weakest treatments we have for MS. So these are old studies and they're small. And it showed that there was potentially an increased risk of relapse with IVF in women who were getting the GnRH agonist medications. So for a while, we're saying, okay, try to use a GnRH antagonist. These are some of the hormones they use in IVF. Then there were other small studies that showed, well, it's probably a risk with both types. So there's really not one that's better than the other. Again, is this real? There was some confounding bias in these studies. They're very small. It's hard to say, honestly. There are no good, large, robust studies on women with MS undergoing IVF, also while being protected with today's excellent disease-modifying therapies. But this is one of the reasons that I like my patients undergoing IVF to be on some form of disease modifying therapy, and preferably a good one, like a stronger one, is because of these studies. So I do not usually recommend that women stop their meds before IVF. I do recommend that they continue them through if they've been well controlled. If they haven't been well controlled, that's something we definitely want to do before they start IVF. The other thing is that IVF is very, at least here in the US, very, very expensive, very time consuming, very difficult and stressful on the body. And so, one, you want to make sure that your body is as ready to take it on as possible and in as much balance as possible. And so the medications can help you get there. You're not worried about an MS attack or having an MS attack, God forbid, as you're trying to do IVF. Because the other thing is that, fertility, there's a lot of question about whether stress is involved with that, right? And infertility specifically. And so you don't want these extra confounding things being thrown at you as you're trying to go through this very difficult and very expensive and draining process of IVF. So partly because of those small, not very good studies showing there may be an increased risk of relapse in women with MS undergoing IVF, and mostly because we want the IVF to be as successful as possible, I do recommend that my patients are on a good disease-modifying therapy and we've controlled their MS before they start that process. And then the failed IVF, I think that what that's referring to is that if it's a successful IVF and you happen to get pregnant, then those pregnancy hormones take over. And we know that pregnancy hormones are protective against MS, which is really nice, a nice benefit. So I think that's why the failed IVF is the issue here. And that's the way that that's usually written, is because then you're getting the hit from the IVF hormones potentially, but you're not getting the protection of a successful pregnancy and those hormones afterwards. So then you're kind of left more open to an MS attack. Carly's asking, can a patient still expect a good level of relapse protection when moving from a high efficacy drug like Ocrevus to a lower efficacy drug like Copaxone? So this depends on the patient, obviously. Every brain is different. Every immune system is different. Some people will do just fine. On a population level, though, say you take 1,000 people with MS and give them Copaxone, another 1,000 people with MS and give them Ocrevus, the Ocrevus group is going to have fewer relapses. That's just what we know on an average level. Now, do I have patients who've been taking Copaxone for a long time and are doing beautifully? Yeah, they're getting tired of the injections, but they're doing fine. Their MS is well controlled. But on average, the Ocrevus is going to give you much better protection against new lesions on the MRI, new relapses, and disease progression in the long run. The concept of starting with a high efficacy drug and then taking it back down and kind of stepping back to a lower efficacy drug in the long run is a very interesting one that we are starting to study a little bit in MS. There's a lot of questions around when is it okay to stop disease modifying therapy in people who are older? When is it okay to blast an immune system with a high efficacy drug and then back off to something milder like Copaxone? We don't have answers for these things yet. So again, it's not something that we have a specific answer for. Everybody's different, but on average, Ocrevus is definitely going to give you more protection against relapses than Copaxone. Monica's asking, are rebound attacks common after delivery? So this is a complicated answer. So for a long time, we thought, yes, they are, but a few different things go into this. So one of the things is a woman's pre-pregnancy disease activity. So if she had highly aggressive MS and had relapse after relapse before getting pregnant, yes, when she delivers, the hormones from the pregnancy will kind of leave, right? They'll go back to normal hormonal state, and the protection that those hormones confer also gets less and less. And so we think of the anywhere between like 2 to 3 to 6 months postpartum as the danger period for a relapse. And so I definitely usually would try to get my patients back on disease modifying therapy before then. Now, one caveat to this is that exclusive breastfeeding may protect against MS attacks. It is likely to, based on a few kind of retrospective population studies. So what this means, exclusive breastfeeding, is that you're not supplementing with formula. The baby hasn't started eating food yet. So really you're going to get like up to 6 months, maybe up to 12 months, but really it's up to 6 months with exclusive breastfeeding. So there is a danger of a postpartum relapse. It usually happens between 3 to 6 months. Is it a higher risk than the pre-pregnancy relapse risk? We used to think so based on an old French study from like the 80s. There's been more recent data out of Kaiser in Southern California that shows that that postpartum relapse risk is probably equivalent to the woman's pre-pregnancy relapse risk. But again, that protection that she's getting during her pregnancy wears off at about 3 to 6 months, and then it's time to get her back on disease-modifying therapy so that there's no relapse at that point. Sophia's asking, are there recommendations regarding how long to breastfeed versus how quickly one should get back on DMT? Excellent question. We're kind of actively trying to address this in our group as to how we should approach this. So for a long time, the conventional wisdom and the way we did things was to be as conservative as possible and say, well, we don't have data on whether the breast milk is getting it, or whether the disease modifying therapy is getting into the breast milk, and whether if it is, it's then making its way into the baby. And if it is, if it's making its way into the baby in levels high enough to affect something within the baby. And you can imagine that's usually like an immune issue, right? Because these are immune medications. So because we didn't have that information, we played it safe. And by we, I mean all MS physicians, right? And not just me in particular. We played it safe. We said, we don't know. It's probably better not to try it out on your baby, right? You don't want to be the guinea pig with your child, your newborn. So no DMT, you either breastfeed or you go back on your medication. And for your safety, we strongly recommend you go back on your medication and you don't breastfeed. And, there was this whole movement of like fed is best, which means that breast milk and formula are essentially fine and it's all good. And we really want you to get back on your disease modifying therapy. So that was the stand for a very long time. Still the stand a lot of us take today. It is the conservative approach. But, as a mom who breastfed my baby, I completely understand why someone would want to breastfeed their child. As a physician, I've seen the studies that formula and breast milk are both fantastic. So whatever works for you is fine. And this is what I tell my patients. But I understand that desire to want to at least try to breastfeed, right? So I'm also coming at it as a mom who was there with you. So now what do we say, right? So there are some medications that you should not take and breastfeed. And these are typically the oral medications like Gilenya, again, least favorite coming up. There's a theme here. Gilenya, Tecfidera, right? These are small molecules. They're going to very likely get into the breast milk, very likely get into the baby, right? We don't want that. But there are some medications that are likely safe. So the interferons are one of them. I think in Europe, they're going to change their label soon to allow that. And then the other ones are the monoclonal antibodies. So these are molecules that are very likely too big to make it into the breast milk. And there have been some small studies now actually evaluating how much Tysabri, Rituxan, Ocrevus make it into a mother's breast milk. And it is at a very tiny, diminishingly small percentage, right? Way below the percentage that's considered safe for a baby for medications to be taken in. So for all we know, these medications are safe to use during breastfeeding, specifically talking about after colostrum, right? So the colostrum is that initial breast milk, really condensed goodies of immune globulins and things like that come out in the first few days postpartum. So that's probably too concentrated. I would not recommend disease modifying therapy while producing that. But once your full milk has come in a couple of weeks after delivery, it is probably likely totally fine. I know I'm using a lot of vague words, right? Because we don't have like the official stamp of approval to do this. I'm just telling you the science and what makes sense. It's probably totally fine to be on these monoclonal antibodies, these larger molecules that barely make it into the breast milk and barely like a hint makes it into the baby. Other fields like rheumatology and gastroenterology that also treat autoimmune diseases allow their patients to do this. And there has been one study that I'm aware of that actually looked at, okay, these babies' moms were taking rituximab, and they looked at what the immune profile looked like in the baby who had drank the breast milk of the mom who was getting rituximab while breastfeeding. And what they found is that the baby's immune system was normal. It was fine. So even though the baby got a vanishingly small percentage of this medication in the breast milk, it did not seem to affect their immune system. There were no extra infections or hospitalizations for those babies. So that's the most reassuring kind of data. I can't wait till we have more of that, where we actually measure the immune system in the baby that's being breastfed. And it's important, obviously, that their immune system is normal because we don't want them hospitalized. They're these teeny tiny vulnerable creatures. And we also want them to have a good response to their vaccines. We don't want to take away any part of their immune system while they're getting vaccine after vaccine every doctor's visit that first year, right? So that's the kind of data I want to see. There is a little bit of there already, but a lot of MS specialists in this day and age will say that it is okay for a mom to go on those medications and to breastfeed. And that's important because we definitely want the mom protected. We want her back on disease-modifying therapy soon after delivery so that she's able to stay physically strong and active and able to take care of her tiny newborn. Okay. So Savda says, I'd like to know, how does going back to medications for Tecfidera work after delivery? So this is a very easy one to restart after delivery. I usually just do a blood check, make sure the labs all look fine a couple of weeks later, because they're going to be a little wonky right at the time of delivery as far as white blood cells and that sort of thing. But I'll do some labs. We'll get started back on. You got to keep in mind that these medications take a few months to kick in. So Tecfidera is one of them. It takes about 3 to 6 months to kick in after you restart it. Same with the interferons. Tysabri is a little bit faster. The infusions like Ocrevus and rituximab are a little slower than Tysabri, a little faster than the orals. So getting back on, really the only kind of bump in the road there is the breastfeeding question, which we just addressed. But once that's answered one way or the other, just some labs and then restarting the medication. It's usually pretty simple, especially Tecfidera. I think you can get it like a week or two after your doctor puts in the prescription. So it's very fast. What I do recommend, what I have my patients do, is that I have them schedule a visit with me, like I said, after they find out they're pregnant, because they'll have a million questions and it's just a happy time and we can talk about that. Or about, we'll do that visit early in the pregnancy, and then we'll do another visit at about 7 to 8 months to talk about the logistics of what it's going to look like. Are they going to try to breastfeed? What medication are we going to get back on? What's the timing? And we'll do the paperwork at that visit for the new prescription, because I've been there. The last thing I wanted to do when I had a 2-week-old and I hadn't slept and I was still healing myself was worry about like filling out paperwork and faxing it or emailing it back into my doctor's office, right? So we get all that ready before the delivery, and the mom knows what the plan is so that she just has to kind of like follow it after and not be thinking too much in her happy but very sleep-deprived state postpartum. Is there a high risk of relapse after delivery since the medication is stopped during pregnancy? So I think I already addressed this. Let me know if there's anything that wasn't clear in this. Just throw it in the chat. But there is a risk of relapse. It is probably just equal to the pre-pregnancy relapse risk in that woman, just based on how her MS is. But we think of that as happening at around 3 to 6 months. You're in that danger zone of the postpartum relapse risk. So we want to get people protected well before they hit that time frame. Justina asks, is the COVID vaccine recommended when pregnant? So I mentioned this at the beginning. I am a neurologist. I am not an OBGYN, but literally every single OB group, society that I have seen has said it's not only safe when pregnant, it is highly recommended, because COVID itself is dangerous to pregnant women. There are reports of unvaccinated pregnant women, unfortunately, being in the ICU, passing away before they can meet their baby, or God forbid, delivering so early that the baby didn't make it either. So yes, I am not an OB/GYN, I am a neurologist, but I've read about this, and every single professional OB society that I've seen highly, highly recommends that women who are pregnant do get the vaccine and get protected against COVID. OBs, they do recommend. Yep. All right. So, sure. You're very welcome. Okay. So Carly is asking, have I noticed a shift from infusions like Ocrevus, like injectables, to injectables like Kesimpta for new moms? Do they consider it to be more convenient to take at home? So Kesimpta is a new medication. It's been out for just over a year. It's been in trials for a few years, though. We were one of the sites for the phase 3 trial for it back, I think, starting in like 2018 to study it, maybe before that. This is a medication that essentially works the same way as Ocrevus. So it has the same cell target. It does the same thing. It's equally as efficacious. It has the same risks because it does the same thing. But it is an injection that you do at home. So it does not have the infusion reaction risk that Ocrevus does. And for a lot of people, it's more convenient because you do it at home by yourself. It is once a month. It's not once every 6 months. And it is an injection. So you do have to do it yourself. So if you're super needle phobic, it may not be for you. It comes in like an auto injector, so you don't actually see the needle, but for some people, they don't want to do that. So I've offered this to a lot of my patients on Ocrevus, not just new moms. And some people have chosen to stay on Ocrevus because it is convenient. You just get it done and you're done for 6 months, right? That's it. And then other people, especially those who had really demanding work schedules and were struggling, or travel schedules, were struggling to make it back to an infusion center that was open during the week or on the weekend, or whatever, trying to find time for that. They are the ones who have switched over. I don't have a lot of patients so far, but my experience has been really good so far. They tend to really like it. So if it sounds more convenient to you, that's really the only difference, right? It's how it's delivered. The risk is the same, the efficacy is the same. So it's really about the patient and what he or she wants. So definitely talk to your doctor if you think that just taking a small shot under the skin, it's not like a deep needle. It's more like a Copaxone kind of level, or beta serum kind of level, deep depth shot. If that sounds doable to you once a month, and it sounds more pleasant than going to an infusion center for half a day every 6 months, that could be a good option for you. And I would definitely recommend talking to your doctor. I think I would. I mean, I think to me, that sounds a lot more convenient. But again, people who are stable on Ocrevus and doing well don't want to rock the boat. Totally respect that. And other people are either tired of needles from years of doing the injectables, or just don't want to do a needle therapy, and respect that too. So they're both great options. Sure. No, you're very welcome. I'm glad you guys are finding this useful. Throw any last questions in the chat real quick before we wrap this up. I do want to address a question that I was messaged by not one, but multiple different women who couldn't make it tonight. And they were asking about the risk of miscarriage in MS. Is having MS something that increases your risk of miscarriage? And the short answer to this is no, it does not. Unfortunately, miscarriages happen quite a bit, especially during the first trimester. But there have been a few small studies that show that having MS does not increase your risk of having a miscarriage. It's just kind of something that happens quite often to women, especially early on. There are, as we discussed, some medications for MS that can harm the baby. So there are medications that should not be taken and potentially could cause malformations that may increase risk of miscarriage down the line. But that typically is not the case. Those are typically malformations that unfortunately just happen or could happen to the baby, and don't result in a miscarriage in that way either. So no, it's not a risk that comes with MS, thankfully. All right. And hi, Sahar, you're so welcome. All right. And then off topic, last question. Am I doing consultations for patients in Canada? So yes and no. Yes, I am. So it really depends. The pandemic has opened up our ability to do virtual consultations quite a bit. So obviously, if you're local, some people even fly in internationally. You can come to Cedars-Sinai. Just Google me in Cedars-Sinai. You'll see my name. You'll see the phone number for my clinic. That's the easiest way to find out if I'm able to see you. The International Health Department at Cedars is also very, very robust, quite excellent. I work with them closely. So if you're international and you don't want to fly into LA to see me and you want to do a virtual visit, call them, talk to them, or email them. Basically, it comes down to the medical licensing in your country or even in your state. The pandemic has even opened up virtual visits for other states, which we could never do before. It's a little more restricted now that the crisis, at least part of the pandemic, is over. But call the International Health Department. They'll let you know if your country allows me to do a virtual visit. Basically, if my license is covered there, what their restrictions are. But so far, I have done a couple of visits for people in the Middle East, so video visits, which is really exciting. I'm just so happy to be able to offer that finally after years of wanting to do that and people asking. So I don't know about Canada. I haven't done that yet. I imagine they're a little more restrictive, but call our International Health Department and see. And Sophia, thank you for this comment because this wraps it up so nicely. It's reassuring to hear that pregnancy and MS is not a no-no anymore, and that there are so many strategies to manage and navigate the process. So beautiful comment. Thank you for bringing that up. I should have mentioned this in the beginning, really, because so many women, even today, even like a month ago, one of my patients came from an OB who was excellent, I know her. She's very well informed. Who told her, like, you probably should not get pregnant if you have MS, right? This was a thinking for a long time, is that women with MS should not get pregnant. It's dangerous. Should not try to take care of a baby. They can't. Should not breastfeed, right? So that is old school thinking. Throw it out the window. Anyone tries to tell you that, cover your ears. Don't listen to them, okay? If you want to get pregnant and you have MS, you should be able to try, okay? Talk to your doctor, figure out how to do it safely. But you should be able to try to do that if that's what your heart really wants. This idea that women with MS can't and shouldn't get pregnant is very outdated. And I can tell you, a lot of my patients have gorgeous babies, happy, healthy. Well, I don't know about happy, but healthy pregnancies. Happy maybe is a relative term, but it is definitely something that's very possible and can be very safe with the right planning and management. Um, Thank you, guys. Thank you for your nice comments. So it was so nice to talk to all of you. Thank you for your excellent questions. I will do my best to save this for those who couldn't make it, and hopefully we can do another one of these sometime soon. Thanks, guys. Take care.